Thank you, everyone. Good morning, and I want to thank Brookings, but also a good thing, our funders, both SCAN Foundation and Hartford Foundation, which are funding this event, but also our major funders at PHI. And I've been asked to talk about the direct care workforce. And these are mostly the women who provide the care for your loved ones, who are allowed to help them stay at home as they age. I'm sure in many cases they've allowed you to get to work so that because you knew that someone was there caring for one of your loved ones. These are the home health aides, the personal care workers, the certified nurse aides in a range of settings, nursing homes, home care agencies, assisted living facilities. They are, what's most important to understand is that they are a huge workforce. And I think Mark mentioned about $160 billion or so in long-term services and support. Well, about half of that, probably, about 80 billion, is going to the payment and support of this workforce. That means there's over 3 million direct care workers in the country. They are the fastest growing occupation in the United States. There'll be 4 million within the next 6 years. That means there'll be more direct care workers than there will be grade school teachers, K-12. There'll be more direct care workers than clerks or fast food workers or RNs. So it is a critical element within elder care services and disability services, important to the economy, important to elder care services itself or providers, because about 7 out of 10 elder care workers is a direct care worker. And it's certainly important to the consumers and residents as being a lifeline to their support. And yet we have a business model that has an unfortunate low investment, high turnover, low return model. And to just give you a few examples of that in terms of how little we really invest. Over an 8-year period ending in 2007, if you were in real wages adjusted for inflation, per capita spending on healthcare has increased 30%. Salaries for doctors and RNs increased 16%, and for home care workers, wages decreased 3%. And in a really bitter irony, even though these workers serve the healthcare system, 2 out of 5 home care workers do not have themselves health insurance. I could go on, but Mark asked me to be positive. So I've done this work long enough to know that we cannot successfully change policy. Everyone nods their head, but no one really responds to the argument that these are poor workers and they're exploited and they should be paid more. Even though that's true, what we really have to do is create a very positive argument that, in fact, these workers are of enormous value to the system, but they're really underutilized. We're paying about $80 billion a year, 70 cents on the dollar a year tax dollars, and yet we're really not getting what we could from that value. And that what we need to do is design models in which the direct care workforce and family caregivers together are supported so they can play a much more value-added role in the system. So just to place that into a little bit larger context, what we really have throughout the system, rather than a highest and best use kind of model, where we're trying to get the most out of each of our levels of providers, we have a lowest and least model. We have doctors who do what RNs can do. We have RNs doing what LPNs can do. We have LPNs doing what aides can do. And with proper support and training, we have aides doing what family members can do. And so why we do that is because we're rich. I mean, we can afford to be inefficient, or at least we could afford that, at least before. And that now, when we're realizing that that's really, we really run out of resources in that regard, we really have to reverse the model and create models of care in which we're taking the very best out of each level so that each level above can perform at their highest level. And this is where the new models of care framework comes in, because I fear that we may be repeating in some ways the same mistake of these new models of care, over-professionalizing them, having models in which that does not take advantage of the fact that we already are paying for people in the homes. We're already have family caregivers there. If we need to create new models of care in which we are making the best use of what we're already paying for, what we already have available. And that there are beginning elements of that in terms of positive examples, in terms of senior aid models, in terms of additional training that allows for a little bit more responsibility and a little bit more pay, but actually so far they've been pretty marginal. And what I hope in these new discussions is that we can create a significantly higher level of responsibility for the paid caregivers, something between the aide and the LPN, in which, without having to go to college, these workers could be performing many more responsibilities. And again, you're already paying for them. Let's make much better use for them. Just in terms of two last points, in terms of encouraging at the administrative levels, we've been meeting with many of the agencies, leaders, and Assistant Secretary Greenlee included. And what's been enormously encouraging is that for the first time, when we go to talk with each is saying that they are reaching out to other agencies, to HRSA, to CMS, across the agencies, to Department of Labor, and that there's a real commitment that we're hearing to take advantage of each other's resources and really cooperate in order to change these models. And then legislatively, that whether healthcare reform is a damaged brand now or not, it's really clear that what's ascendant is jobs and job creation, and that in this arena, we have opportunities to take these ideas and implement them inside some of the new legislative initiatives, reauthorization of Workforce Investment Act, jobs bills, in which we can get the healthcare workforce solidly supported within that momentum legislatively.